Everybody's on YouTube, on Facebook.
Facebook. Mm-hmm.
Okay, so today's topic is entitled Menopause, New and Not So New Approach to Management. I did give a webinar on menopause about 10 years ago, and it looks like some things are similar and some things have changed a lot. And I'll try to emphasize some of the changes. Today's our my wife and I's 28th anniversary. This is from our trip to Belize. Outline of today's talk is what are the symptoms of menopause? How does menopause relate to other endocrine conditions? How is menopause diagnosed? What labs are needed to diagnose and follow menopause? How can lifestyle changes be used to treat menopause? Is estrogen safe or dangerous? What are bioidentical hormones? What supplements can be used for menopause? And is there a menopause diet? The female reproductive system is outlined here. You have the ovaries, you have the fallopian tubes, you have the uterus, and you have the vagina. There's a cycle of estrogen, progesterone, testosterone that's pretty clear cut. In the follicular phase, which is when I recommend you getting hormones, you have low levels of estrogen, testosterone, and progesterone. And mid-cycle, you get a peak of estrogen. And you can see the testosterone rises a little bit, but not too much. So in general, you can measure testosterone any time of the month. And then in the second half of the cycle, you have a rise in your progesterone. That's the luteal phase. And you have also a rise in your estrogen. So you can see the flattest part of the curve is on day 3. And could everybody make sure they're muted? This looks at the levels of estradiol and progesterone with age. Pre-menopause, you have high levels of estrogen and progesterone. In the menopause transition, the age is 35 to 50. You still get spikes of estrogen and little spikes of progesterone, but it declines between age 35 and 55 or so, 53. Postmenopausal, you have low levels of estradiol and progesterone. Menopause is cessation of menses for 1 year. Most women experience menopause between ages 40 to 58 years of age, with a median age of 52 years. Factors associated with early menopause include lower body weight, menstrual length, not having children, nulliparity, smoking, never use of oral contraceptives, lower socioeconomic class, and race or ethnicity. Higher body weight is associated with later onset of menopause. Some women who go through menopause have no symptoms at all, but most experience some symptoms, often beginning several years before their last period. Perimenopause may be worse than menopause. Can everybody please mute themselves? Why so many doctors fail with menopausal care? Symptoms are underreported and undertreated. Many doctors don't even ask patients about their menopausal status. 42% of people receive no treatment advice. 23% felt dismissed. Rarely do physicians discuss menopause unless the patient brings it up first. Studies of primary care physicians and gynecologists found that the discussion of menopause is initiated by the patient 91% of the time. It's a high percentage. And that the most challenging aspect of treating these patients were due to confusion and controversies in treatment options, which we'll try to clarify today. 65% of women felt unprepared for their menopausal experience. We call this the menopausal transition: unprepared, dismissed, and suffering. I think this woman is a great example of this. The symptoms are often worse than expected. There's fear, confusion, and vulnerability. Unanswered questions happen frequently, and the patient's often dismissed. Definitely, I want to be different than that. The symptoms include about 6% of patients, not too many, no or little symptoms. Mild symptoms is 25%. Moderate symptoms is 47%. And 41% of patients have severe symptoms. That's a pretty high percentage. In premenopause, the symptoms are 19.7. Perimenopause are 46.5. And postmenopause is 85.3. So most women going through menopause have symptoms, many of it quite severe. In addition to fatigue, other common overlapping symptoms that can contribute to the feeling of exhaustion include joint and muscle aches, sleep problems. 86% of people have sleep problems, and hot flashes, 83.5%. Now, this shows the years around the final menstrual period when the patient stops having their periods. You can see one of the first things is cognitive symptoms. You can see then sexual and urogenital alterations start low, but they go up. Depressive symptoms sort of peak around the time of the last period. The sexual and urogenital alterations happen a little bit, usually later in the menopause. Sleep disturbances are quite common, happen sort of around menopause. And depressive symptoms also are quite common, usually around between 1 year before the final period and the final period. So these are a huge number of percentage of patients have these symptoms that again are mostly dismissed or not actually treated. This is what happens to hormones. In early menopause, the estradiol is relatively unchanged. The first thing that happens is the FSH, follicular stimulating hormone, goes up. You have cardiovascular risk factors include the carotid intermedial thickness increases, you have vascular remodeling, and you have worsening endothelial function. So you're getting more things related to clots. There hasn't been that much studies in early menopause, but in general, the early menopause things start happening right away. You can see the weight happening in late menopause. The estradiol goes down, AMH goes down, FSH goes up, body composition gets worse, body fat expands, so the fat mass expands, and the muscle mass, which is really important, your fat free or lean mass, decreases. Your energy expenditure goes down, so you're not burning as many calories. That's why you gain, one of the reasons why you gain weight. You don't oxidize fat, and you can have a decreased energy intake, but not always the case. So all these can lead to this weight gain. You can see the picture of this woman has gained a lot of weight from early menopause to late menopause. Your cardiovascular risk factors increase even more. You have dyslipidemia, worsening your cholesterol profile, the carotid intermedial thickness, the aorta gets worse, vascular remodeling, endothelial function gets worse, your cardiac health gets worse. You have increased sleep disturbances, which we'll talk about extensively. That can lead to problems with your hormones, problems with insulin resistance, so all these in late menopause. And then in post-menopause, your estradiol drops, and it's usually for 2 years after your last period and then stabilizes. Your FSH goes up. Fatty composition continues to get worse. Your fat mass increases. Your abdominal fat gets worse. Your fat free mass gets worse. Your sleep and energy and resting energy expenditure, physical activity energy expenditure, all go down. Fat oxidation goes worse. So all these things contributed to weight gain and feeling bad. A lot of your symptoms. Your cholesterol continues to go up. Your insulin resistance goes up. You get glucose intolerance. Some people can get prediabetes and diabetes, and your sleep disturbances get worse. Now, the terms I've seen used are both hot flashes and hot flushes. Hot flashes are used in the United States. Hot flushes are used in Europe. The medical term is vasomotor symptoms. I think most people like the term hot flashes. Up to 80% of Caucasian menopausal women experience hot flashes. Hot flashes vary with race and ethnicity, with African American white women reporting more hot flashes and Chinese and Japanese American women reporting fewer hot flashes. And perimenopausal women do have a high rate of hot flashes. Hot flashes can be bothersome to women. They can adversely affect quality of life. Treatment of hot flashes, therefore, could improve quality of life, may improve sleep and mood. And then I think the key takeaway points is hot flashes lead to poor sleep. When you don't sleep well, you feel fatigued, you gain weight, some of your hormones like cortisol and leptin go up. So all these things are some of the detrimental issues of hot flashes, why they should be treated. And this is certainly a woman's health issue. The most common symptoms would be some of these things we talked about. Menopause, again, is the cessation of menses for 12 consecutive months. The symptoms, hot flashes are hot flushes, night sweats, insomnia is very common, palpitations, depression, anxiety, memory loss, change in cognition, vaginal dryness, vaginal thinning, urinary dysfunction, change to sexual response and sex drive, acne, hair loss, and irregular bleeding. I want to really place this emphasis, the connection between poor sleep and menopause. Menopause leads to poor sleep, and poor sleep leads to worsening symptoms of menopause. People that sleep poorly, often from menopause, who sleep less than 7 hours a night, are more likely to be overweight, have diabetes and metabolic syndrome. Both the quality and the quantity of sleep matter. So if you're waking up a lot at night because you're having hot flashes, both your quality and your quantity is going to be worse. People can track this on their iPhone, for example. But the quality is you want to go into deep sleep, and this is very significantly affected in menopause. And the menopause leading to poor sleep leads to fatigue, weight gain, insulin resistance, diabetes, and obesity. And the poor sleep itself leads to worsening menopause symptoms. So again, it's a vicious cycle. Poor sleep leads to menopause. Menopause leads to poor sleep. The hot flash physiology is not completely understood, even though I gave this talk 10 years ago. I don't think there's been much improvement on it. There's not a direct correlation between estradiol levels and hot flashes. In general, with the drop of the estrogen level, withdrawal of estrogen is necessary for induction of hot flashes. It's a narrowing of the hypothalamic thermoregulatory set point or thermoneutral zone. I'll show this on the next slide. So this means people sweat easier and shiver easier. So you have a narrowing of that temperature. Thus, a small increase in core body temperature results in heat dissipation response experienced as a hot flash. Again, could everybody mute themselves? Please mute yourself. Amy, please mute yourself. Roxana, please mute yourself. Robin, please mute yourself. Apple. So this is this sweating threshold. You have this thermoregulatory zone, and you have a thermoneutral zone where in normal asymptomatic women, premenopausal women, it's kind of wide, so they're not either sweating or shivering. With hot flashes, this zone narrows, so people start sweating more and shivering more, and therefore you can often feel hot, but also some people feel cold all the time. So this is one of the important issues of hot flashes and seems to be related to this physiology. So estrogen withdrawal can lead to increased norepinephrine. You feel like you get a little bit like adrenaline rush. There's a very important metabolite, MHPG, is the primary brain metabolite of epinephrine. That seems to go down. Increased activation of alpha adrenergic receptors, reduction of the thermoregulatory zone, autonomic reactions to cool the body are affected, and you get hot flashes. Okay, so what kind of tests do I recommend doing? The first one is I recommend, while a woman is still having periods, to get a day 3 FSH and estradiol. And basically an LH is not terribly helpful, but the FSH, when it starts going up, is consistent with perimenopause. That FSH between 15 to 30 is consistent with perimenopause, and greater than 30 is consistent with menopause. An estradiol level less than 40 on day 3 of her cycle is consistent with perimenopause, and less than 20 is consistent with menopause. Very important, and we'll talk about this a little bit more, the hormone called SHBG, sex hormone binding globulin, binds to estradiol. So if you have a high SHBG, your estradiol will look higher. If you have a low SHBG, your estradiol will look lower. So the results vary a lot with patients, needs to be repeated often and interpreted in the context of the patient. What are the different hormones like in different conditions? In menopause, the testosterone is low, the estradiol is low, the LH is high, the FSH is high. In hypopituitarism, the testosterone is low, estradiol is low, LH is low, FSH is low. And in PCOS, the testosterone is high, estradiol varies, LH is usually high, FSH varies. Cushing's, it varies a lot, so I didn't put that up as a row, but in general, Cushing's, you might have lower testosterone, lower estradiol, sort of normal LH and FSH. So both hypopituitarism and menopause have lower estradiol. So a patient that has hypopituitarism and menopause, their estradiol could be especially even lower and might even be especially more symptomatic. In general, as I mentioned, in menopause, the LH and FSH go up, but in hypopituitarism, they go down. So you may not have an elevated of LH and FSH if you have both of these conditions. PCOS, a common condition. I gave my webinar about it last time. We're getting a product called Symetra coming on board pretty soon to treat it. And it usually lessens in menopause, but a lot of times it doesn't go away. And then you have this high LH to FSH ratio in PCOS. There's a hormone called anti-Müllerian hormone, AMH. It's a very important test. I think it's underutilized. It predicts egg quality in menopause. In a study of 35 to 39-year-old premenopausal women, the mean time of menopause was 9.94 if your AMH was low, and 13 if your AMH was higher. So in general, a higher level of AMH has been a positive correlation with natural fertility in women aged 30 to 45. This is only statistically. If some patient has a low AMH, it doesn't guarantee that they're going to have trouble conceiving, but it's an indication. I measure this hormone frequently. I think it's quite helpful. This can be measured any time of the day and any time of the cycle. Now, testosterone declines with age. This is pretty dramatic here. So you look at this figure on the left. This is total testosterone level with age. Sort of peaks around 18 to 20, and by 50 or 60, that's about a fifth of the level of the peak. And by 60 and 70, it really declines. So you do have this decline in testosterone, which I think is quite significant. The next slide on the right looks at testosterone in males and females. The testosterone is also peaks around for males, peaks in the 20s and 30s and 40s, declines a little bit with age, but the testosterone in females especially declines and with age. The estradiol is also quite high during reproductive areas or time and drops postmenopausal. So testosterone, I think, is a forgotten hormone. Many of my patients go on it; they like it a lot. Um, Symptoms of low testosterone in women include decreased muscle strength, osteoporosis, libido changes, a low mood, fatigue, thinning hair, baldness, anxiety, depression, vaginal dryness, and cognitive change. So a lot of symptoms. Um, that my patients have. Testosterone has roles of enhancing libido, promoting muscle development, stimulating red blood cell creation, increasing skin collagen production, promoting reproductive health, encouraging bone growth. So it really does a lot of things. It helps the brain with spatial memory. It helps prevent estrogen proliferation in the breasts, increases muscle and bone formation and mass. It helps prevent anemia. It influences functions related to reproduction and helps with skin collagen contact, which is very good. But what happens if you take too much testosterone? High testosterone is associated with symptoms of PCOS, the same things we talked about last webinar: acne, loss of hair on your head, breast swelling is rare, allergic reaction super rare, headaches, change in libido. Sometimes your libido gets better. Voice changes and extrafacial hair are the more common ones. Less common ones are quite rare: blurred vision, blood clots, fluid retention. So I want to emphasize the difference between bioavailable, free, and total testosterone. The bioavailable testosterone is what, in general, what I often measure. Testosterone is usually 20 to 80 nanograms per deciliter. Most of it is SHBG bound, so it has sex hormone binding globulin binds to about 60%. The albumin bound is 35 to 40%, and the free is like 2%. So there's not that many free testosterones around, especially women. So I don't think the assay is that great for low levels unless you do by equilibrium dialysis. There's a direct assay, there's a calculated assay for free. In general, I like the bioavailable testosterone. It's readily available at the labs. It measures free and albumin bound biologically active testosterone, and it's accurate, it's reliable, pretty for the most part. I like that level between, say, 3 and 7 is optimal. The SHBG, as I mentioned, is very important. In general, low SHBG is associated with insulin resistance, diabetes, and obesity, and I would consider that bad. High SHBG in general is good. But if your SHBG is high, your total testosterone and your total estradiol, SHBG binds to both testosterone and estradiol. So the total can look high, but in actuality, it could be the free or the bioavailable could be normal. So measuring total testosterone alone, I think, is very misleading. I never really recommend doing that. The free testosterone is often low, inaccurate at low levels. So I usually recommend, at least in concert, the total plus the bioavailable testosterone. And I like a level between 3 and 7 for the bioavailable testosterone in women. Okay, I'm going to talk about the Women's Health Initiative study. This is a very important, controversial finding. Um, Observational studies. So these were studies that looked at women on estrogen. They had lower rates of heart disease. There's confounders. The women that are on estrogen went to their doctors more. They're probably higher educated. So it was originally thought that estrogen had beneficial effects on the heart disease. When I was doing my endocrinology fellowship at the NIH, Gordon Cutler taught me that estrogen therapy for postmenopausal women, they saved 1 million lives. It was quite dramatic. So along came this Women's Health Initiative. It was a large prospective clinical trial of postmenopausal women. They were trying to look at heart disease. So instead of looking at women that are 50, you would expect for a menopausal study, they looked at women with an average age of 63. The drug at that time used was called Premarin. It's conjugated equine estrogen. It means it comes from horse urine, was something that I think when people think about it, they wonder why we ever use that. And then there's also estrogen plus progesterone, called Prempro. If you had a uterus, if you didn't have a uterus, you just got Premarin. And the question was, could it prevent chronic conditions such as heart disease and dementia? The estrogen with the progesterone portion of the trial ended early. Again, this was about 2002 due to increased risk of breast cancer. Again, this was Premarin, women in their 60s. There increased risk of blood clots, stroke, heart disease among women who received this treatment. The estrogen alone arm in women with hysterectomy showed no detrimental effects and a possible decrease in coronary artery disease when women age 50 to 59 were analyzed. There was a lot of sub-analysis of this afterwards. And I think in general, the conclusions were like that women around the menopausal age, the estrogen may have been beneficial. Only when it's gone into the later era, it does look more detrimental. And again, only this is relevant for Premarin. The benefits of hormone replacement therapy in the Women's Health Initiative include prevention of osteoporotic fractures, colorectal cancer, and the effect on dementia was unclear. And these findings were only applicable to women taking Premarin and Provera. Oral estrogens, such as what's given here, oral Premarin and Provera, and another one called estrase, affects liver proteins, leads to clotting. Some of the effects may have been because it's called a first pass effect. When you take oral estrogens, it goes to the liver. When you take estrogens by patches or gels or creams, it seems much safer. So since that study came out, the use of Premarin and Provera plummeted, while the use of creams, gels, and patches has risen. Many women, after hearing these contexts, often taken out of context and sensationalized, sought safer treatment, redirected bioidentical hormones, or stopped them completely. Many doctors stopped giving hormone replacements altogether, letting patients just struggle with their symptoms. A reanalysis of the data looking at 8,000 women, a lot of women in their 50s who enrolled in the study, found that unlike their older counterparts, this group faced no increased risk of heart disease during the study period. So is estrogen safe or dangerous? I think that's the struggle. We're worried about, do no harm. I think some people were worried about breast cancer. When you think about it, breast cancer takes 20 years to develop. So it's unlikely that a woman got breast cancer at 55 and was on postmenopausal estrogen for 5 years. The estrogen was probably playing a role. But that was a concern. And there's been a change. So I got this article, the Free Press. I really like to read that. It's called Estrogen's Back. It has this woman on the left side before estrogen and the right side after. The quote's Dr. Jessica Navarro. Beside estrogen for hot flashes, more women are using it as a facial cream, beauty products for vaginal dryness, such as pain on intercourse, and vulvar atrophy. I use it every night, and I feel like my skin is more hydrated, less red, my fine lines have softened. Estrogen is the key to aging well. And there's a growing number of providers, doctors, that are pushing estrogens now, and I think that some of the emphasis has changed. So I want to show this YouTube video here of the head of the FDA, Dr. Makari. He says,
You might have to stop this screen share and share that one.
right. I'm not sure why I can't stop the screen share. Good technology day.
Maybe press exit.
Yeah, let's do it here. Okay.
There you go.
Can people see this?
Can't see it yet.
Want to put that fear machine in its proper context and let people know that there are tremendous long-term health benefits.
In fact, you say hormone
on during a sort of pile-on bandwagon
of American women going through perimenopause or menopause.
So we're removing the black box warning from many of the estrogen products. That warning was put in a sort of pile-on bandwagon thinking. It was a group think in 2002, 2003, that women really should not be taking these products because of the risks. We now have a more nuanced understanding, and we want to put that fear machine in its proper context and let people know that there are tremendous long-term health benefits.
In fact, you say hormone replacement therapy can be a breakthrough for women.
Yeah, arguably, with the exception of vaccines or antibiotics, there's no medication that can improve the health of women on a population level more than hormone replacement therapy. For example, it reduces the risk of fatal heart attacks significantly, up to 25 to 50%. Well, that's the number one cause of death in women. It reduces cognitive decline. It may prevent Alzheimer's. In one study, reduced the risk by 35%. And it improves bone strength and prevents osteoporosis, which is a common cause of a cascade of events later in an older woman's life after, say, a fall or an accident. Fractures lead to immobility and ultimately could lead to a woman's demise. So there's tremendous long-term health benefits, not to mention the short-term benefits of alleviating the symptoms of menopause.
What does this announcement mean for the tens of millions of American women going through perimenopause or?
Okay, so I think that's quite impressive. Is estrogen? Can people see my screen again? Still?
Yes, you can see it.
Okay. Estrogen is safe or dangerous? Marty Malarkey says it's an American tragedy. I do think it's one of the biggest mistakes in modern medicine. Marty Malarkey told the 50 to 70 million women over the last 23 years have been denied the incredible life-changing, life-saving benefits of hormone replacement therapy because of the dogma. And you could see the link in the CBS News. So the U.S. FDA removed the black box warning on many hormone therapy drugs used for menopause and perimenopause about 2 months ago. A major turnaround that's likely to encourage more women to seek treatment. And in fact, since the FDA lifted the black box warning about 2 months ago, prescriptions for hormone replacement therapy have increased 86%, leading to shortages of estrogen patches. I have patients that are saying you can't get the patches. We'll talk about some different alternatives for patches, but I think this is a life-changing change. And I thank Dr. Malarkey for his insight into this. Dr. McGarry. The treatment for hot flashes is primarily estrogen therapy. Estrogen therapy has a greater than 80% efficacy in relieving vasomotor symptoms, so it's quite effective. Prior to the Women's Health Initiative, estrogen therapy was widely advocated. Following the publication of the WHI, there was a marked decrease in estrogen use due to perceived risks with estrogen. In general, you want to avoid oral estrogens and birth control pills. Both of those lower IGF-1. In general, most of my hypopituitary patients are on growth hormone. I would say oral estrogens is the one contraindication, one drug people on growth hormone should not take. For some people, it's okay, it's not an issue, but many of my patients do worse on oral estrogens. There's a common birth control pill called Northindra or Slind. I think it might be a little bit better, but the gynecologists are using that quite frequently. It also lowers IGF-1. It lowers bioavailable testosterone, which could be good if you have PCOS. But in some of my hypopit patients, we talked about how important the testosterone is. You don't want to lower it. It also can lead to blood clots and weight gain. So in general, I would say a woman over 40 should probably not be on birth control pills. Maybe a younger woman is ideal. Vival Dot is my go-to estrogen patch. It's a small patch. It's twice a week. It usually is covered by insurance. The Climera is a larger patch, given weekly. Other patches include the Dottie patch. Dottie patch is becoming popular. Patients that can't get a Vival patch can go to a Dottie patch. They're basically interchangeable. Everybody, please mute themselves. There's one called a Minivel. There's one called a Laura. There's one called Menostar. Sometimes they fall off and need to be tapered on.
Sorry, Dr. Friedman, yeah, that's better.
Okay. And there's combi patches called estrogen plus progesterone. I like oral progesterone. I don't like progesterone patch. So I usually give people oral transdermal estrogen plus oral progesterone. Compounded creams are another option. We'll talk about them. And in general, I think there's more of an emphasis on giving people, even with their uterus removed, progesterone. Progesterone has a lot of benefits. And I think there's more of a movement to give everybody progesterone, if they don't have a uterus. The estrogel, I like that one also, 0.06%. That's a topical gel. Usually start with 1 pump a day, given on the inner arms. Sometimes the insurance covers a little bit harder with it, but it's an excellent product. I like to measure your estradiol levels. I aim for an estradiol level between 50 and 100 micrograms per mil. If the patient is still having menses, it should be done on day 3 of their cycle. If no menses, it can be done at any day of the cycle. Estrogen is bound to SHBG, so I recommend getting an SHBG usually when I get a estradiol. It's part of the bioavailable testosterone sort of package. And the high SHBG could mean a total estradiol high, but the free can be normal. And you can measure free estradiol. I often do that in my patients. Progesterone replacement. Women with uterus need progesterone. Um, if you give estrogen without progesterone, you can get endometrial buildup, and that could lead to endometrial cancer. I usually give bioidentical progesterone. It's called prometrium, or just it's called progesterone is the generic. I don't like the synthetic Provera. The Provera is medroxyprogesterone. It's not bioidentical. And I often work with gynecology colleagues to get a transvaginal ultrasound. The thickness of the endometrial thickness on transvaginal ultrasound should be less than 5 millimeters. If it's more than that, sometimes they need higher doses of progesterone or lower doses of estrogen. Progesterone helps with hot flashes as well as estrogen, and also helps with sleep. Progesterone rarely leads to fatigue. Occasionally can lead to a little bit of swelling, bloating, waking. Usually doesn't, but I usually have people take the progesterone at night. If you give it at night continuously, like 200 milligrams, you don't get a period usually. If you give it for part of your cycle, such as 10 days, for example, the menses will occur a few days after the progesterone is stopped. I usually give people a choice. Women less than 45, I usually encourage them to have a period, but some of them don't want a period. While greater than 45, I usually have them not take a period. Prometrium is progesterone. It's bioidentical. Again, I usually give the 100 to 200 milligram dose if no period is desired, and 200 milligrams for 10 days a month if period is desired. And you can give progesterone to somebody without a uterus. You just don't have to. Somebody that's having side effects, that you can give it just infrequently. You can give it every 3 months. Just make sure you monitor that uterine lining. So progesterone replacement is crucial. In patients without a cycle, I start patients on days 15 to 25 of the calendar month because people aren't having a period. And then I move it to 15 to 25 of the menstrual cycle. I usually give a compound. I often can give compounded progesterone creams, but they're a little bit less absorbed. Some people like them quite well, but I usually like the prometrium or progesterone pill. Don't recommend Provera. And I usually don't monitor progesterone levels, but occasionally I do. Now, testosterone is a crucial hormone. It's the underrepresented, underappreciated hormone. I usually give it in women with symptoms of low testosterone, low libido, weak, low muscle strength. People that should have a bioavailable testosterone less than 2, especially women with hypopituitarism. Menopausal women frequently have low testosterone levels. I like a compounded gel, usually 1.25 milligrams per mil or 2.5 milligrams per mil. I get it from University Compounding Pharmacy. There are male preparations that are cheaper, but it usually gives you a high level. It's very hard. You have to give it just a teeny bit of it to get it to work. So I like the topical better. The pellets I definitely recommend avoiding. They give sky high levels after the shot, after the pellet, probably higher than my level, and lower before the next pellet every 3 or 6 months. It's definitely non-physiological. And I aim for physiology in general. I like to have the bioavailable testosterone level between 2 and 7. Sort of again what a normal woman should have. Side effects include facial hair, acne, hair loss on your head. And most patients really like the testosterone. It's a game changer. What are some other treatments for hot flashes? The pharmacological alternatives include SSRIs like sertraline, Prozac, SNRIs like Effexor, gabapentin. These have about 60% reduction in hot flashes, but I don't think they work as well as estrogen, and they have more side effects usually. Some recent studies have found that gabapentin is one of the key drugs that leads to higher rates of Alzheimer's disease. It gives you fatigue, trouble sleep, makes you tired, weight gain. So I usually don't do these alternative drugs. I would rather just put somebody on estrogen and progesterone. And then the other option is supplements, which we'll talk in a second. Meditation, deep breathing is another option. While it may not stop hot flashes entirely, it can significantly reduce the intensity, and anxiety associated with them by calming the nervous system. You could do a cooling breath called Sitali Pranayama. Curl your tongue into a tube or your lips, or part of your lips if you can't. Inhale deeply. Feel the cool air entering your body. Close your mouth and exhale slowly through your nose. The stop method, use this method for 10 seconds to interrupt the panic loop. Slow down, take a deep breath. Observe the sensations warm in my sorry, this cut off a little bit. But the stop method is an idea. It's a good idea also. What are bioidentical hormones? And this is a controversial area. Bioidentical hormones are defined as compounds that have exactly the same chemical and molecular structure as hormones that are produced in the human body. They have been promoted as safe and more effective alternatives to the traditional hormone therapy offered by people outside of the mainstream medical therapy. And then any hormone can be made bioidentical. The term is often used to describe formulations containing estrogen, progesterone, and androgens, often from natural sources or from synthetic sources, but the one the body makes. So they can be made by extracting deoxygen from plants, usually these high-yield soy or Mexican yams. And it's structurally similar to steroids. It must be changed into progesterone, which is then used as a precursor to make bioidentical hormones such as androgens and estrogens. These isomolecular hormones are identical to those found in women and therefore are purported to be better tolerated and more appropriate to treat menopausal symptoms. And this was especially important, I think, when there was the Premarin, which is very non-bioidentical. Now that we have estradiol creams and gels, that's also bioidentical. It's a little less of an issue now. Suzanne Summers, who I like very much, wrote a couple books called The Sexy Years, Discovered the Hormone Connection, The Secret to Fabulous Sex, Great Health, and Vitality. But, she tried to make some money off of this also. She had a couple books. She had a company and did a lot of food lines, fitness products. Unfortunately, she died at the age of 70 through her breast cancer in 2023. According to its advocates, the bioidentical estrogens are more what the body makes. There's 3 bioidentical estrogens: estriol, estrone, and estradiol, and which estriol is the most, but it's very weak. Estrone is probably detrimental, so I usually don't give that, but estradiol is what the body mainly makes, compared with Premarin, which has several other synthetic estrogens, which are not bioidentical. Estriol appears to antagonize the proliferative effects of estrone and estradiol, while it has less tendency to stimulate endometrial proliferation. Estrone may have detrimental effects on the breast and is not recommended. Natural progesterone has benefits over synthetic ones, as I mentioned before. I like progesterone over progestins, which are Provera or medroxyprogesterone. Natural progesterone affords the same protection against endometrial cancer as synthetic progesterones, but doesn't interfere with the body's ability to protect against heart disease. So the mainstream organizations, American College of Gynecologists, were against compounded bioidentical. And then there were some issues that the FDA was compounding on these. But in general, I use some bioidentical compounded estrogens. But I think with the really excellent availability of things like a Vital dot patch and estrogel, there's not as much need for these as there was before. So I use bioidentical estradiol and progesterone, what the body makes. I often get it from prescriptions, but sometimes compounding pharmacies. I especially like the Vital dot pad and oral progesterone, which are bioidentical but not compounded. What can a patient do to balance their hormones and improve menopausal symptoms? So we're trying to get back to what the patient can do. So some of these are common sense things. Some of these are part of my talk on lifestyle medicine. So I'm really interested in having patients do what they can to do. So eat high fiber whole foods, move, sleep better, stress management, and the supplements we'll talk about. Now, as I mentioned earlier, there's a lot of detrimental hormone changes associated with the menopause: decreased muscle mass, lower resting energy expenditure. You burn about 300 calories a day less than you did before menopause.
No.
So just to break it, please mute yourself. So your weight gain is common. Body weight in menopause is recommended. to correspond with your energy intake according to your body composition. Basically, I don't recommend people to like fast, but in general, people should try to lose weight if they're able to, if they can, and eat healthy foods. Salt consumption should be limited. And I'm really a big fan of a vegetable diet. I have my vegetable revolution on my website, and try to eat 3 to 4 servings of vegetables and 1 to 2 servings of fruits per day. This will help you with menopause as well as your overall health. So you shouldn't eat well below your basal metabolic rate. It has a risk of low energy availability and may worsen menopause. So you should avoid starvation diets. But in general, I like people to eat a little less, try to lose weight, try to drop that weight 1 to 2 pounds per week. Maximize fat loss, minimize, preserve lean muscle mass, try to do weight training if you can, and then always do lifestyle changes. This should be long-term effects and not a short, quick diet. The American College of Lifestyle Medicine advocates the 6 pillars of health. Pillar number 1 is good for both life and health, as well as menopause. So I took this from the American College of Lifestyle Medicine. It's a whole food, plant-based diet. Whole foods mean single ingredients foods, unprocessed or minimally processed foods as they exist in nature. So you can see that on the lower right there, the carrots and papayas and mangoes and zucchini and things like that. Single ingredient as they exist in nature foods. Plant-based means that most of your calories should come from fruit, vegetables, whole grains, and legumes. Legumes are quite beneficial for menopausal symptoms also. So most of your food should come from these type of foods. A whole food plant-based diet leads to weight reduction, reduce visceral fat, the fat around your organs, and decrease some of the symptoms of depression and fatigue, things like that. So I would recommend for a menopausal diet, soy products are good. Fruits, especially berries, have a lot of antioxidants in them. Vegetables, leafy greens, whole grains, beans, nuts, and legumes. Plant-based foods rich in calcium. I don't think people should get calcium from external sources, but from your plant-based foods. Fish has some controversy with the plastics in it, but in general, I recommend fish for menopausal issues, and unsaturated fats in moderation can be added. This shows someone else's idea of a menopausal diet. Tomatoes have antioxidants in them. Eggs are a good source of vitamin D. Vitamin D. Tofu has high in soy. Soy is beneficial. I'll show that on the next slide. Radishes could be helpful. Greens are helpful. Feta cheese can be helpful. And seeds such as chia seeds are also have a lot of nutrition that are helpful for menopause. Foods to avoid in menopause: red and processed meat. Studies have found those are the most detrimental. Sodium-containing foods. And I love this picture of I show this to my patients at Power Obesity. Ultra-processed foods versus processed, minimally processed. Corn is minimally processed. It grows on the ground, grows in the Central Valley. Canned corn is a little bit processed. It's still pretty much corn. Doritos has a little bit of corn in it, but not too much. It's mostly preservative chemicals, additives, flavorings, salt, sugar. So you want to avoid those ultra-processed foods. It leads to worsened physical function, cognition, and also menopausal issues. Fruits and veggies have phytonutrients. These are very important to help you with menopausal symptoms. When you eat a whole food, there's a lot of different colors in the foods, increases the bioavailability. You get a lot of these phytonutrients, which helps make sure that you don't have symptoms of menopause, and fiber is crucial. Soy has isoflavones in it. It's associated with reduced inflammatory bacteria, associated with heart disease risk reduction. There's some evidence for improving hot flashes. The isoflavones in soy foods help balance hormone levels and have some estrogenic activity. Try to eat it as a food and not as a supplement. Fermented foods are also quite effective. Miso, tempeh, pickles, yogurt, kimchi. They support gut health, cardiovascular health, and potential help with mood and benefits related to menopause. Good sleep hygiene. We talked about at the beginning. Poor sleep leads to menopausal issues. Menopause leads to poor sleep. It's important to try to go to bed the same time at night. Don't eat before you go to bed. Get enough sleep. Aim for at least 7 to 8 hours. Try to get restorative sleep, and don't stay up real late at night, and have a normal circadian rhythm. Stress management is crucial. Some people like taking baths, spending time with bath salts, candles, a day at spa. So connect with your spiritual sources are always good things to help with your menopausal issues. Supplements. Okay, supplements are key. My favorite one, my number one go-to supplement in general, is vitamin E. Really works well for hot flashes. Other ones are curcumin, magnesium, flaxseed oil, evening primrose oil, and B vitamins. There was a study of 51 patients. There was some issue that there was a question about the study, but I think it's been proven. Other studies have shown it also. There was a different, when they gave either placebo or vitamin E, the people on the vitamin E had lower hot flash scores. Their frequency was less. It was highly significant. And it's recommended for vitamin E for treatment of hot flashes. I like vitamin E. Sometimes I even give it with estrogen. Little side effects. It's an antioxidant, which means it helps prevent oxidation of tissues. It also is helpful for fatty liver disease. Turmeric is the whole root, the rhizosome of the curcuma longa plant, while curcumin is the active ingredient compound in it. Think of the turmeric as like the orange, and curcumin is the vitamin C. So try to get these into your diet. Curcumin also reduces hot flashes as anti-anxiety, antioxidant, and anti-inflammatory. Magnesium can help reduce symptoms of menopause. I usually have people take it at night. I like magnesium glycinate. It helps with insomnia, tissue dryness, mood swings, anxiety, irritability, and water retention. So it's a good supplement to take if you're having menopausal issues. Flaxseed oil, you can grind it up. They have a substance called lignans in it. They're important modulators of hormone metabolism. These can be quite helpful for hot flashes. Evening primrose oil has gamma-linolenic acid, an essential fatty acid that helps with prostaglandin synthesis. It helps moderate menopausal symptoms. Black currant is also quite helpful. B vitamins, B6, B12, and B9, folate are essential for managing common menopausal symptoms like mood swings, fatigue, cognitive decline. They support neurotransmitter reduction, energy metabolism, combat brain fog, which is associated with hormone shifts. So I think taking a multivitamin that has these in, or taking these especially, are good ideas. Okay, so I think we did a pretty good job here. Please look at my website, Good Hormone Health. This will be posted in a couple of days, also on Facebook, on your YouTube channel, on my podcast channel. If you have any questions, you can email us, and we can go to questions now.
Awesome. Thank you, Dr. Friedman. I can start on Facebook.
Okay.
Danielle asked, or she said, Dr. Friedman, maybe you'll get to this, but can you talk about how BLA might affect onset on symptoms?
So when you have a BLA, you're missing your cortisol, mineralocorticoids, fludrocortisone, DHEA, which is also an androgen. And you're usually taking cortisol, sometimes too much cortisol that can affect your estrogen. So in general, I think if you're properly replaced after a BLA, you should have the same menopausal issues as a regular person. If you're improperly replaced, you may have more issues.
Awesome. We have another question. What about instant sweating right out of the shower, sweating profusely, just blow drying your hair?
So I think that sounds like you're having menopausal issues. You need to either go on estrogen or go up on your estrogen or consider progesterone.
Okay. Elias, I thought that the later analysis showed that the older women that had negative outcomes were associated with a longer gap for treatment.
Right. So most of them didn't get treatment until well into their 60s. I think the newer analysis says if you treat a woman around 50, it's usually beneficial.
For those of us that are panhypopituitary and need to do a blood draw, if we have had vaginal estrogen added Monday, Wednesday, Friday to help with a variety of symptoms, including interstitial
Interstitial.
yeah. Do we need to do anything specific for timing of lab/vaginal estrogen that is inconsistently taken?
I think if you still take it 3 days a week, it's probably going to be fairly consistent. One issue I do see, especially with testosterone, but sometimes with estrogen, is people put it on their inner arms near their antecubital vein, and then they get the blood draw and it's sky high. So make sure that if you do put it on your arm, don't get a blood draw at that time. I think if you take estrogen every other day, it's probably not going to be that different from one day to the next day.
Okay. Sherry asks, what about 10 years post-menopause? Weight gain, hair loss, weak muscles, fatigue, lack of sleep, pituitary adenoma present but testing negative for ACTH, etc.
It sounds also like menopause. Menopause can happen right after your last period. It can happen up to 10 years afterwards. So, I think you should look into menopausal issues and maybe go on treatment.
Okay, Cheryl asks, empty cella and menopause, question mark?
It makes it worse. So women with hypopituitarism, they have lower estrogen to begin with, including empty sella, and therefore, when you get menopausal, you get more symptoms than otherwise, and maybe need a higher dose of your replacement.
Mm-hmm. Hey, Amy says, happy anniversary, Dr.
Thank
Friedman.
you.
Question 1, is there a connection between premature ovarian failure and low cortisol? And if yes, can you explain why? My menstrual cycles began stopping before and after being suspected of adrenal insufficiency.
So both premature ovarian failure and Addison's disease are autoimmune diseases. They often can run together, although certainly not most of the time, not always, but sometimes they can run together. And you can get autoimmune attack on your ovaries, autoimmune attack on your adrenals, and you can get both of them. And I would say both of them need to be properly treated with your cortisol and fludrocortisone for your Addison's, and with your estrogen and progesterone and testosterone for your menopausal issues. And people with Addison's also are missing some testosterone from the adrenals. So your testosterone in women, more of it is made, maybe 60% or so made from the ovaries, but a proportion of it is also made from the adrenals. So if you have Addison's disease, you may need more testosterone.
Well, question 2, MPA is supposed to be lower cortisol. However, I was prescribed this another time. My menstrual cycle stopped again, and it was helping my energy, memory, muscles, and digestion, but never 100% on a daily basis. Times I was quite ill with low cortisol symptoms, and labs were reading that glucocorticoid steroid in the MPA, and then prescribed over FDA recommended amount of oral estradiol. The MPA only lasted so long, and eventually the MPA quit working. Why would MPA do this?
So MPA is medroxyprogesterone. I don't recommend that. I would recommend sticking with bioidentical or progesterone, and I don't recommend oral estrogens.
Okay. Lolly asks, until how many years after menopause can you start estrogen/testosterone, etc.?
Okay, that's a good question. I was going to have a slide on that. I think when the WHI came out and there was this backlash, I think, and the WHI being women in their 60s, I think most doctors, and maybe even including me, felt you give it to for 10 years till you're 60. But then you have people in their 60s that are benefiting from it. They stop it, they get hot flashes still. It still has the benefits, the cardiovascular benefits, for instance, the hot flashes. Sometimes they give it in the 70s, and I have some people on this call probably that might be in their 70s. They're still taking estrogen and testosterone. So I think it varies. You might want to give the dose a little less as you get older. But I think if you're having menopausal issues and you're in your 60s, you can consider going on it.
He asks, as a congenital panhypopituitarism 48-year-old woman, when would I decrease my current estrogen and progesterone?
Yeah, so I think that was sort of the same question as last time. I would usually keep people on their estrogen and progesterone until they're 60 and then sort of reassess. Um, some people you want to keep it in their 60s. A few people you want to keep in their 70s, but usually I would try to reassess.
Okay. When should women begin being tested for perimenopause?
No, I think when your periods start becoming irregular or you start having symptoms. Um, and I'd recommend start with a day 3 FSH and estradiol level.
Mm-hmm. Jen asks, many of my friends have been prescribed progesterone only, but I was prescribed both estradiol and progesterone. Why would one be prescribed uh, over the other one?
I think the general estrogen is probably more beneficial for menopausal issues than progesterone. So I usually give both. There's certain exceptions. People don't tolerate estrogen, didn't tolerate estrogen as well. They had side effects on it. They want to just go on progesterone. I think it has to be individualized, but most patients I put on both estrogen and progesterone.
Mm-hmm. Shauna asks, where should we apply the topical testosterone?
I put it on your inner arm and then sort of rub them together like this. But make sure you don't have it there when you have your blood draw.
Okay. Janet asks, it seems to be unclear how progesterone should be replaced. Did you recommend taking progesterone on days 15 to 20 per night? Many doctors are recommending not taking every night of the month. What are your thoughts on cycling
So
biogenital?
So if you take it days 15 to 25 of your month, you'll likely have a period. If you want to have a period, if you're less than 45, I usually recommend having a period. If you take it continuously, you probably won't have a period. And for the people that don't want to have a period, I recommend it continuously, like every day of the month, either 100 or 200 micrograms. And I usually recommend it at bedtime, 100 or 200 milligrams.
What are your thoughts on compounding time-release progesterone from university compounding?
I usually give the progesterone oral prometrium or progesterone. I think that works pretty well. Some people I put on creams. I don't particularly use a time release one. The other thing is some people have peanut allergies. Most of the conventional progesterone prometrium are made with peanut oil. So some of the people with peanut allergies, I might switch to compounded.
How do you handle symptoms of both hyperthyroidism and menopause? They both exhibit the
Right,
same symptoms.
Yeah, good point. I was going to put a slide in that also. So they're very similar symptoms. Treat them both. Treat the hyperthyroidism.
Across from Lenny's.
Treat the hyperthyroidism and treat the menopausal issues.
Okay. APS, I'm almost 52 and may be starting to experience symptoms, but so far they have been minimal. I think night sweats, extreme fatigue, not sure about other stuff like dizziness and vertigo. Till I have mostly regular menstrual cycles, does it make sense to start treating how to be proactive, or should I wait until experiencing symptoms?
I think it depends on how bad your symptoms are. As you said, night sweats and extreme fatigue. It doesn't sound too mild to me. It sounds like you're having a lot of symptoms. I think the sleep is the crucial thing. If you're having trouble sleeping, I think I would start the estrogen. And as I mentioned, the supplements, especially vitamin E, might be a good choice to start if you don't want to go on estrogen.
What?
Okay, one more question, and we'll call it a night.
Debbie asked, does estradiol vaginal cream, is that useful for vaginal dryness?
Yes, absolutely. The advantage of the vaginal estradiol is an advantage and disadvantage. It's not systemic, so it helps vaginal dryness, but it doesn't get into your systemic level, so it's not going to really help you with hot flashes.
Do you recommend another medication?
The vaginal, if you should just take estrogen if you're having hot flashes. That will help your vaginal dryness also.
Okay. How much vitamin E should one take?
400 units.
Okay, and then one more question.
That's
Is
it.
there a benefit to take estrogen if you don't have any symptoms?
That's a good question also. So, I think if you're having concerns about osteoporosis, for example, you might want to take it. If you have like early menopause and you have thin bones on either your bone density or the urine peptide, I might take it. But I think in general, we try to treat people with symptoms.
Awesome. Well, if anyone has any more questions or want to see Dr. Friedman, please visit growtohormonehealth.com, and happy anniversary.
Thank you so much, everybody. Thanks for joining us.
Thank you.